Yeah, apologies for the delay there. So I think Dr. Arindam has already spoken about the quality of life scores. And we now know that ARNIs are approved as class 1 indication for patients with heart failure with reduced EF. Now the data gets a bit murky and there is a certain confusion that happens when we're talking about the mildly reduced EF or the persons with preserved ejection fraction. And that's where my focus would be to try and see what the evidence is there in patients with the mildly reduced and the preserved ejection fraction. So when we look at the mildly reduced ejection fraction patients, and now that the guidelines tell us that anything less than 40% is reduced EF, 41 to 49% is mildly reduced EF, and anything more than 50% is preserved EF, we know that these patients who present with preserved EF have a different subset of clinical presentation. They are usually women, they are obese, they have atrial fibrillation, they have many metabolic risk factors, whereas patients who have the low or the reduced ejection fraction tend to have more of ischemic heart disease. They tend to have more of LV dysfunction, producing renal dysfunction. So these are more common in patients who have the reduced ejection fraction, whereas patients with the mildly reduced ejection fraction tend to fall between the two. So when we look at the mildly reduced ejection fraction, the ischemic heart disease component is similar to the patients with the reduced ejection fraction. So these patients have ischemic heart disease as one of their primary reasons for LV dysfunction. Whereas when you look at the renal disease, patients with mildly reduced ejection fraction tend to have more renal disease similar to the patients with HFpEF, because they often tend to have many of the associated comorbidities. They tend to have atrial fibrillation or many of the other metabolic syndromes that patients with preserved ejection fraction may have. And therefore, the treatment mostly falls into the category where most of us would treat a mildly reduced ejection fraction similar to our patients with reduced ejection fraction. And therefore, it was suggested that drugs which are useful in patients with reduced ejection fraction may also be equally efficacious in patients with the mildly reduced ejection fraction. This is something that, again, as I said, patients with mildly reduced ejection fraction often tend to have ischemic heart disease and new ischemia as one of the reasons for their clinical presentation. And disease, there is evidence also in the trials to say that ischemic etiology is a common feature in patients with the mildly reduced EF, similar to patients with the reduced ejection fraction. Now, what is the data that we have for patients with mildly reduced ejection fraction? So this is a small study which was done, published recently, almost last year, which looked at the efficacy of sacubitril valsartan in treating patients with heart failure with the mildly reduced or the mid-range ejection fraction after myocardial infarction in diabetic patients. So when we go to the MI studies with valsartan sacubitril, I think we had a negative study there, though the statistical data was not reached, but there was a lower figure in patients who were on sacubitril valsartan as compared to ramipril. So this study is one of the studies which has looked at the biochemical parameters. So it has looked at ejection fraction. Here it looked at the ejection fraction after a period of 12 months of initiation of sacubitril valsartan in patients with a mild reduced ejection fraction after the myocardial infarction. And they found that the LV ejection fraction improvement is significantly more in patients with on sacubitril valsartan. And similarly, you get an LV remodeling. You get a better LV, lower LV dimensions after 12 months as compared to baseline once patients are on sacubitril valsartan, and a lower risk of rehospitalizations in the mildly reduced ejection fraction or the mid-range ejection fraction post myocardial infarction. So this study is different than the previous study, which was done in patients with reduced EF. So this is a study which is a positive study, and this gives us some hope that you can possibly have data to use it in patients in the mid-range of ejection fraction. Similarly, we all know that many of the data that we have looked for, and similar to an SGLT2 inhibitors also, ARNIs have also had a dual effect. Not only do they have an effect on cardiovascular prevention, they also have effect in renal protection. And this is one more study which has looked at the outcomes of renal dysfunction in patients with the mildly reduced ejection fraction. And again, this is a slide that we all know from our physiology days. There's a vicious cycle that goes in patients with LV dysfunction and in heart failure, and the renal function lipid progression that happens over a period of time. Creatinine is an important biomarker, and this study that we are talking about, it looked at creatinine, and a creatinine of almost 1.3 was the cutoff mark. Patients who have renal dysfunction also are definitely, along with LV dysfunction, are at worse risk of having future events. And again, this is a slide which is a little busy slide, but what again we understand is that patients who have association between LV dysfunction and renal dysfunction is much higher in patients who have LV dysfunction. So patients who have HFrEF or HEF with mildly reduced ejection fraction are more likely to have a renal dysfunction associated with their LV dysfunction rather than patients with HFpEF, where the renal dysfunction may be a little lesser. Again, benefits of sacubitril valsartan in patients with heart failure reduced EF and mildly reduced EF, and patients with coronary artery disease and CKD was assessed. And again, this showed that there was a positive result. Sacubitril valsartan did result in a benefit in terms of improvement of renal function and a reduction in the deterioration of GFR over a period of time. Coming back to guideline recommendations, earlier for the patients with mildly reduced EF, ARNIs were prescribed earlier only for patients with reduced ejection fraction, where we know that it's a class 1 indication. For the mildly reduced EF or for patients with preserved EF, we only had diuretics as the class 1 indication. And we had data from SGLT2 inhibitors, which were put it in the class 2A category. But with the recent guidelines, ARNIs have been given a 2B category, where the data says that there is some evidence to say that you may consider using ARNIs in patients with the mildly reduced or with preserved ejection fraction also. So there's a 2B recommendation, and this is based on certain studies that we now know of. So these are the guidelines now. So what is the evidence that is coming up now? So there is biochemical difference, definitely. So when we know that when you look at NT-proBNP, definitely there's an improvement when you're using ARNIs. There's an improvement in quality of life scores, also similar to the reduced ejection fraction group of patients. And we know that it reduces the readmission and the hospitalization rates with heart failure in this group of patients. So is this a time for us to adopt it in all the spectrum of patients, irrespective of the ejection fraction? Well, there is now data which is now looked at the pool data from Paragon and Paradigm HF. So Paragon HF was a preserved ejection or data which looked at preserved EF, where the EF was more than 45% in the group of patients of Paragon. And Paradigm HF was, of course, with reduced EF. And when they did a pooled analysis of these group of patients, what they found is that patients with the mid-range, though Paragon was a negative study when you look at statistically, but when they did a subgroup analysis, they found that the benefits could extend even till an ejection fraction of 57%, or in ladies especially, so women had a better outcome. But again, when you look at all outcomes in terms of reduction in total heart failure hospitalizations or the risk of cardiovascular death, there was a tendency towards a reduction in the pooled analysis of Paragon and Paradigm. Now, coming back to recent evidence, so this is a late-breaking discussion. The Paraglide HF trial, this was published recently at the Prague Heart Failure Meet. I've lost the slides, okay. Okay, so this is basically, now we know for sure that for patients who have a reduced ejection fraction, there is data. But for mid-EF, mildly reduced EF, or for preserved ejection fraction, there was still a data that there's a paucity of data. Now, Paragon HF was, the criteria for Paragon HF was that these patients should have to be stable at least for a period of 6 months. So they should not have had an episode of acute heart failure hospitalization within the last 6 months, or they should not have had an acute myocardial infarction within the last 3 months. Now, unlike the Paradise-MI trial, the Paragon HF trial looked at it beyond 6 months. But we know that many of our patients may not be waiting for 6 months, and most of the guidelines are not talking about early initiation of ARNIs. So therefore, the Paraglide HF trial looked at an early initiation of ARNIs after an episode of heart failure hospitalization. And this was done either inside the hospital or within a 30-day period. And what they did is they looked at biochemical parameters at 4 weeks and 8 weeks. And they also looked at secondary events in terms of cumulative composite endpoints of heart failure hospitalization and composite of renal worsening also. The other thing to note is that in this trial, the systolic blood pressure cutoff was kept at 100, and the eGFR cutoff was more than 20. So they looked at more a more sicker group of patients than the Paradigm HF group also, where 30 was the cutoff. And in this trial, this is again important because the Paragon HF had shown women showing some benefit. And therefore, the Paraglide HF again had almost a 50% or women who were included in this trial. And again, if you look at this slide here, you can see that when you have a subgroup analysis of the ejection fraction, you had an ejection fraction of 40 to 49% in almost a quarter of patients, 50 to 60% in 52% of the patients, and another quarter had supranormal EF of more than 60%. So these are patients who are real life patients, and these here patients were randomized in hospital in almost 70% patients. So here the patients were started on medications early, unlike the Paragon HF where we had started late. And a subgroup analysis of Paragon had said that probably an early initiation of heart failure of ARNI would have made the difference. So this was a positive trial in terms of biochemical improvement. So there was a reduction in the NT-proBNP of almost 15%. And this is something that I think all of us now look at is the win ratio. So when they looked at the win ratio of sacubitril valsartan over valsartan alone, there's almost a 19% win of overall, there's a 40% win of sacubitril versus 31% with valsartan. But when you look at all the components, whether it's heart failure, hospitalizations, urgent heart failure visits, or cardiovascular death, there is a win of sacubitril valsartan over valsartan alone. And again, when they looked at an ejection fraction less than 60%, what we normally would call as the preserved ejection fraction, again, you see that there is a win, and this win is more in the patients with the ejection fraction less than 60%. So anyone more than 60%, we still would say that we don't have enough data, but less than 60%, probably we still have, we can say that we could probably benefit from ARNI also. They also looked at additional outcomes in this Paraglide HF trial. And what they found is that the composite endpoints and the recurrent renal endpoints were also in favor of sacubitril valsartan. Safety was also a concern for us, much lesser in sacubitril valsartan as compared to valsartan alone, though not statistically. And there was no increased incidence of hyperkalemia or symptomatic hypertension in sacubitril valsartan as compared to valsartan. So to summarize, I would say that we now have data to say that in patients with reduced ejection fraction, we know that, yes, we must start sacubitril valsartan early. When it comes to mildly reduced EF or in patients with preserved ejection fraction, well, the data says that you should think of opt-out. So we have to say whether the patient would benefit. And if the patient cannot be given, we need to have a reason to say why we are not putting these patients on an SGLT2 inhibitor or an ARNI or an MRA. So for a low ejection fraction or reduced ejection fraction, it's always an opt-in where we'd want to start these drugs. For a preserved ejection fraction or a mildly reduced ejection fraction, it is an opt-out where we have to exclude these patients and see which of these benefit. There is data possibly to suggest that we would have reduced NT-proBNP, and we have improvement in terms of reduced hospitalizations and possibly an all-cause mortality. And these benefits are more when you have a patient more towards the reduced EF. So when you have a patient who's probably in the range of, say, 45 to 60, these are the patients who are more likely to benefit rather than someone who has an EF more than 60%. So with that, I'll stop my talk here, and I'm happy to take any questions.